All right. Hi, everybody. Thank you so much for joining us today. My name is Gina Petty, and I am the Executive Director of the Sudden Cardiac Arrest Foundation. We're really happy to have you join us today for the webinar on challenges in rural out-of-hospital sudden cardiac arrest. Um, if you are new to the foundation, I just wanted to take a minute to introduce us about the Sudden Cardiac Arrest Foundation. So we are a national nonprofit organization. Our vision is to eliminate preventable death and disability from sudden cardiac arrest and support those who are affected by sudden cardiac arrest. And our mission is to raise public awareness of sudden cardiac arrest and promote initiatives to help save lives through education, research, and community. So if you would like to connect with us more, please visit our website. It's sca-aware.org. We're happy to talk with you more about getting involved or accessing more of our information and resources. But without further ado, I wanted to introduce today's presenter, Dr. Michael Levy, who is an EMS physician and emergency medicine physician practicing in Anchorage, Alaska, with a specific practice focus on improving community outcomes in life-threatening, time-critical emergencies. He has practiced emergency medicine for over 3 decades. As an emergency physician, he has provided frontline care in remote and urban environments, as well as serving in administrative roles, including department chair and president of the hospital medical staff. The majority of Dr. Levy's clinical practice is now in EMS medicine. He is medical director for the Anchorage Fire Department and for Anchorage area-wide EMS. He is the medical director for emergency programs for the state of Alaska and has the honor to serve as the medical director for a number of other Alaska EMS agencies. Dr. Levy is the president of the National Association of EMS Physicians, the Alaska PI for the Heart Rescue Project and president of the Lauren Marshall Foundation. He is the chief medical advisor for Stryker Emergency Care and the medical director for Global Medical Responses International Motorsports Association Medical Program. Dr. Levy is a faculty member of the Seattle Resuscitation Academy and serves as a senior consultant for the Academy. He has served on a variety of national committees and expert panels and is a published author on a number of scientific articles. He's based in Anchorage, Alaska, where he is an affiliate associate professor with the University of Alaska Health Sciences and practices community-based emergency medicine. Dr. Levy, it's such a pleasure to have you joining us today. Thank you so much and welcome. Oh, you're on mute.
And let's see, I have to ask you to allow me to share.
Oh, sorry. Let me stop mine.
Yep.
There you go. Sorry about that.
Thanks for that great introduction. It looks like I have to update my bio a little bit. I'm a past president of the National Association of EMS Physicians, which was an honor and still an active member. And I'm no longer the medical director for the EMSA portion of GMR Motorsports, but that was a great gig as well. So really great to see some familiar names out there. Let me see if I can successfully navigate the thing I've done more than once or twice. And there we go. How's that look, Gina?
Great. Thank you.
Okay. Well, again, thanks so much. So happy to be here. Again, these talks are often more cries for help than solutions. So I'm looking forward to any feedback people have to help us work through what I find to be a really challenging and opportunity to improve outcomes in rural healthcare. Let's see here. Here's my disclosures again. As stated, I'm the chief medical advisor for Stryker Emergency Care, and I'm on the scientific advisory board for the Celebrate trial, which is now concluded. So today, what we're going to talk about is rurality in the USA and how that might affect outcomes from out-of-hospital cardiac arrest, and really what's really the challenges we do find in rural areas as opposed to urban. How big of a problem is this for the United States? And does the thing that we talk about these days mostly, is it really applicable to our rural environment in terms of our resuscitation academies, other things we've used as anchors to improve outcomes? And is there anything we can do to leverage all this great technology we have these days to help improve outcomes? So, Alaska, lots of beautiful pictures. It's a beautiful place, no question about it, but it's a big place. People see it basically down here in the Gulf of Mexico most of the time as a little inset. But honestly, it's a pretty big place. So a third the size of the United States, essentially going coast to coast with all of our archipelagos and the like. And the other thing that's interesting about it is we're mostly roadless. So in South Central Alaska, we have some roads. We have one road that goes up to the oil fields, the Hall Road, but mostly the vast part of our state is roadless. When you look at our state, just as kind of a little geographic romp here, Anchorage is the largest city in Alaska, and it's about 300,000 in population. So, it's a large urban area. We have a large catchment area of 1,700 square miles. So that makes us larger than Rhode Island. And it's the fourth largest city in the United States by area, but and the population density of 165 people per square mile. If we look out more broadly, just a little thought question, what other US cities are geographically larger than Anchorage? And of course, I had to look this up too, but give that a thought. And the quick answer is Sitka, Alaska, Juneau, Alaska, Wrangell, Alaska. Those are all larger. Those are the only cities in the US, according to my sources, that have more square miles than does Anchorage. When you look at how rural we are, one of my services is in the Kenai Peninsula Borough, which is known to most people as the place where you used to catch very, very large king salmon and still can catch lots of salmon. And this is a very large area as well, 24,000 square miles. A lot of it's water, a lot of it's land. Population density, even though has some minor urban areas of several thousand people, population density is only 3 per square mile. Population of Soldotna, when I checked it last, was 4,500, and that certainly swells during the summertime when tourists are in. If you go a little bit further north up to the Fairbanks area, which is kind of also where Denali is, if you kind of route reference to that, there's a number of different service areas in there for EMS. But again, this is a very large area, as large as New Jersey. And we've got 95,000 people scattered around there, but it can be very, very rural. If we go back and look at what has been one of our guiding lights for improving outcomes in out of hospital cardiac arrest, the Medic One Foundation, it's been Seattle King County and all the great things they've done. And mostly not just what they've done in terms of their survival, but the way they've shared it through the resuscitation academies. And as a consequence of that, we've all sort of aspired to see what we can do to replicate the amazing transformation in survival from out of hospital cardiac arrest that's been witnessed in the Seattle area. And again, we've seen numbers in the 50-60% range for people with witnessed out of hospital cardiac arrest with bystander CPR. So we use that as kind of the anchor for thinking what could be done. But and really that's led to what I would categorize as survival percentage envy, where we're all trying to aspire to that. And some days we hold our heads high, and some years we hold our heads a little lower because of not being able to meet those goals that we'd hoped for. The problem with using percentages as your guideline for how you're doing as an outcome is that so much of it depends on how much data you have to use. So if you look at one of our rural volunteer services up here, looking at the 2019 year, they had 0% survival. This was on 4 witnessed arrests with initial rhythm of VF and only 2, and ultimately no survivors. So that's very disheartening. However, if you just go fast forward a couple of years, we have 50% survival based on basically 3 witness bystander arrests, 2 with VT. And so again, the numbers can be important because we went from 0 survivors to 1 survivor, and that 1 survivor is a fantastic thing. However, when you continue to go through these things, you find that these numbers can just be a little bit misleading. So here in 2019 is another rural agency and 3 witness bystander arrests and 100% survival. So if you're doing the press release, that looks pretty good. If you're, but you go a couple years forward and now you're at 0%. So you're buoyed up and you come back down. But still, we had 2 lives that were saved. If we look at just rural versus paid, we see kind of the same sort of thing in my world, at least. And if we look at the small urban services, again, we're seeing very small numbers. So it's hard to know what to make of all this, but we can definitely anchor on the idea that regardless of what the percentage was, we had survivors. We caused something important to happen by taking somebody who was well and truly dead and then having them survive and go back to their families and their network of people that they influence. When we look at our data, if you look at, for example, Anchorage, this is some older data from Anchorage, and it's not so important what our response times were, perhaps, but we have usable data here based on 150 run volume in that case. And so we can at least start seeing where things are landing and how we might move things around to improve. When we look at smaller agencies with a run volume for cardiac arrest of 2 runs, for example, then the response times become kind of all over the map, and we start looking at how we change these things. There's process changes, but there's also just incidental things that need to be changed, and so it's hard to know what to make of that. So one of the basic precepts of the Resuscitation Academy, and it's really important, is we measure and improve, and it's that measurement that makes it's fundamental to how we get to the next step. But when we have data that isn't as large and isn't as refined, and honestly, when we have folks like me that aren't the whiz kids from Seattle to kind of parse these data, this gets a little harder to make sense of in terms of how to follow our data, at least on a larger scale. Which is not to say that we don't need to go back and review each and every run. Of course we do, and see what we can learn from that in terms of process and some other measures like that. When we look at, I'm just using Alaska as an example. If I use the 3 largest cities in this 8 time period of 3 years versus all other agencies that we're reporting, the Epstein bystander survival rate, if you can see it on your screen, was about 43% for the larger cities. And for the small cities, for the rural areas, it was in the order of 30%. What does that mean? There's definitely a difference there. Is it statistically different? I don't know, but it's different. So if you look at this, and we take these little boxes we put in the CARES reports, and we look at the non-traumatic survival rate in rural versus the non-traumatic survival rates in the larger urban areas, there's a big difference there. And it's based on different numbers, but it's a big difference. So I'm saying, is that delta, is that difference your rural survival tax? Is that the price you pay to live in the country, and be out with the trees and the lakes and the animals and stuff like that? So maybe that's just a thing, right? We just kind of know that if you're in the backwoods and you twist your ankle, it may be different than if it happened, at a shopping mall. But this is a little bit bigger than a twisted ankle. If you look at the data that exists, those data that go back and try to see in a larger scale what the outcome was of urban versus rural, and these are in different countries as well, are urban victims more likely to have EMS response less than 8 minutes? And the answer is, you are not going to get a fast response in a rural area. Urban victims are more likely to be discharged alive. So there's a lot of information that kind of goes down this same pathway, that if you're in an urban versus a rural setting, you have a lower likelihood of surviving out of hospital cardiac arrest. Looking at population density and outcomes in Victoria, Australia, very low density, much poorer chance of overall survival. Out of hospital cardiac arrest, an area of more than 3,000 people per square kilometer, you had 4 times more likely to survive discharge than if you're in an area that has a very low population density. So there was this massive improvement if you're in an urban location. Now there's a lot of the US that is rural. And as folks on this call, I know that there's a lot of different ways to define rural, but you kind of know it when you see it. And we have a lot of rurality in the US. At minimum, it's 20% of our entire demographic is rural. And so, one definition is, as I have here from the US Census Bureau, but there's other ways of defining it. Nonetheless, we have a lot of rural settings in the US. Okay, well, so this is from our LifeLinks program, and just one way of looking at the systems of care. There's different diagrams we could use, but this is pretty straightforward. I think we've all accepted that how do we move the needle to improve survival from out of hospital, cardiac arrest. Well, we need to get an immediate notification to 911. And then 911 needs to be equipped with telecommunicators who can rapidly assess the situation, identify cardiac arrest, and initiate lay rescue or telecommunicator CPR. So early cardiopulmonary resuscitation becomes really important and something we can leverage through telecommunicator CPR and other methods as well, such as mobile police units and community-based defibrillation programs associated with CPR. But the next step to this is using CPR to push the death curve out so that we can see if there's a resuscitatable condition there in the field. So if a person has ventricular fibrillation is the goal we're looking for, and rapid defibrillation can, in many cases, convert that to a perfusing rhythm. However, of course, the problem's not solved by doing that. There's something that caused it in the first place. So now we need to move the person to a higher level of care, and that requires emergency medical transport. And of course, with this whole package of the emergency medical transport is the expertise that's brought to the scene for more complicated cases to facilitate resuscitation of people that are a little bit more refractory in their resuscitation. When we take these people, transport them now to a higher level of care, we're delivering them to a hospital. There's hospitals and there's hospitals, right? So we have rural access hospitals and we have tertiary care hospitals. And, you know, which of those places in general can handle the more complex cases? And of course, we know the answer to that, despite all the good works that go on in the more rural areas as well. So when we break these things down, so the immediate call, even, 95% of the US has access to 911. What does that really mean? I mean, it means that the wiring is there, but how many of those really have access to high quality telecommunicator CPR? And I don't have the answer to that, but I know it is significantly less than 100%. And that the impact of telecommunicator CPR is immense in terms of getting early circulation established and converting these people who become very difficult to resuscitate due to too long of a downtime to kind of push things out by having that bystander immediately directed to start CPR, even if they're not trained. Telecommunicator CPR is massive. And the problem is that it's not available across the board. So then, what does it take to get CPR started? Well, again, if we can get TCPR going, that is great. However, hopefully, in most cases, our volunteer EMS services can provide, something they've trained a little harder on, of course, than somebody we're just telling them how to do CPR in the moment. But oftentimes we have long response times. So getting people there, it becomes a big deal. So if we can't bridge that gap, there's a very high likelihood we're not going to do as well. And so I'm saying that, TCPR is not democratic, but it's really important that we find ways to increase access to this important source of care. Rapid defibrillations, again, when you're in the city, we can map all kinds of AEDs. We have hundreds in Anchorage here. We map them through dispatch. What happens out in the community? What happens out in rural areas? There are just not as many out there. Most communities don't have things set up like you might see in Europe or elsewhere, where there's community CPR AEDs that are available even in more rural areas, things that we could work on. Rapid defibrillation is so important for people that have a rhythm that can be defibrillated. But as time goes on, CPR is not sufficient to continue to provide a substrate where defibrillation can provide life-saving intervention. So we need to get that to people as quickly as we can, and we need to come up with ways to make that happen. It takes longer for us in a rural setting to get to the person. Our transport times are longer, and we have a mix of providers doing the care, right? So it's not all paramedic-based systems. A lot of it is basically first responders and non-ALS interventions. And so there's a mix there that is more prominent in rural areas than it is in urban areas. And so that's just another thing that contributes to challenges for us in meeting the same type of things we've seen in urban areas, in rural areas in terms of survival. And then post-cardiac care, again, not to diminish all of the contributions and the great things everyone does out in rural hospitals. But in rural hospitals, we have limited resources. It's just a simple fact. And so if a person has, an obstruction of a coronary artery, aside from using a fibrinolytic, the ability for us to get in and do advanced things, just doesn't exist. So those people need a secondary transport to another level of care. And if they're quite unstable, that is, again, another major challenge. So when we look at rural out-of-hospital cardiac arrest and the survival effect, there's definitely a finger on the scale here. It does tend to be something that is going to be less survivable, quite honestly. But where you live, should it determine if you will live? That's something we need to confront. Because, again, this is an ongoing issue. It's something that has a lot of components to it. But what can we do to help improve it? Well, one thing we can do is get as many resuscitation academies and at least the teaching of high performance CPR out to all of our providers, out to our communities. Again, I've said that it definitely is based in an urban environment, but it's clearly, in terms of the precepts of high performance CPR and of the building a system, that definitely applies to every place. Again, it's just without the population density, there are some more challenges perhaps than what we see in the more urban areas. If you look at Dr. Eisenberg's important book called 10 Steps for Improving Survival from Cardiac Arrest, it definitely encompasses all the things that we try to bring across in the Resuscitation Academy. And of course, this is free online should you want to look into it. But these 10 steps are important. These 10 steps are things that do apply to rural areas. But again, there are challenges. So when you look at Alaska, great group of individuals out in Nikiski, Alaska. But again, this is a large area to cover. We have fewer personnel, fewer bases. We've got some problems just with our environment in terms of roads and access. And it's just, there are just some things built into the way we live that make this thing more difficult. We have fewer cardiac arrests, so we have fewer opportunities to improve on things and less data to work from in terms of being able to sort of round off some of the typical statistical variation. And there's different baseline health characteristics for people that choose to live in this environment as well, quite honestly. This is another one of the things that does fit into the social determinants as well. People have less access to healthcare. They sometimes choose to have less access to healthcare or to access healthcare less. There's issues with insurance and getting access. So there's many things that build a group of individuals who perhaps even a little bit higher risk for cardiac arrest. The volunteerism we see in the States that buoys rural healthcare is huge. It's really important. But oftentimes, it's just difficult to provide the same level of training for volunteer staff than you do for paid staff, just because, volunteer staff are off earning a living during the day. They can't come in for training at 10 o'clock. And yeah, you can shift that to 6 o'clock, et cetera, et cetera. But you all know, it's a challenge to get this done. So, we have this bucolic, wonderful rural life that we can embrace and be out there, and it's wonderful. But the simple fact is that when we're in that environment, we also have some additional risks with regard to things we kind of take for granted in an urban area. But there are differences to this. So if you look at Freddie Lippert's group in Denmark, and they looked at out-of-hospital cardiac arrest in urban versus rural, and they found that in witnessed arrests, there was really no difference in overall survival in Denmark for out-of-hospital cardiac arrest that was witnessed. And you look at these graphs, and this shows both shockable rhythms and non-shockable rhythms, all patients, big span of years, and that the difference was not there. However, this is a population that has taken upon itself to do a lot of training, a lot of bystander CPR goes on, access to defibrillations is different. They have kind of tuned their country to a higher level. And they've shown that in other studies as well. So that's certainly something to aspire to. And it does show that just the way it is doesn't mean it has to be the way it is everywhere, because some places have shown that they can get around that by with an engaged citizenship. What else can we do? Well, the digital witness for cardiac arrest is something that you hear things about these days, and it's something we need to continue to at least keep an eye on and to see if this is going to mature in a way that could really, really make a difference. So the digital witness is some kind of thing that we wear or that's around us or that's a sensor that recognizes when something really bad's gone on. And then it conveys that information to EMS via a dispatch center, and also hopefully get somebody to the scene quickly, which would presumably be nearby responders. So those of you in this call, I guess I would say a high percentage of you have something like this on your wrist, Apple Watch, and you know that it has the fall detection algorithm in it. So it can definitely alert EMS that you've fallen. However, that has not met with great enthusiasm from a lot of people because, for example, ski areas inundate dispatch centers with "I've fallen and I can get up," but it triggers it before they do. So we have to be very, very careful about sensitivity versus specificity when we have technologies like this. There are multiple groups of really smart people that are trying to engineer an approach to this that will have sufficient sensitivity, so the ability to find all the events that occur, versus the specificity of finding just the ones that, hold on, I'm sorry about that. So the sensitivity versus the specificity. So trying to get as many of the events that occur, but getting only the ones that are actually the ones we're looking for. The specificity becomes very, very important. And so that's what the technologies are wrestling with. The thing that seems to bring these things together the best is a thing called optical photoplethysmography, coupled with an accelerometer run through an AI engine. It seems like when you get to the point that you can look for a pulse and also know that a person went kathunk with it in a way that the accelerometer can judge was likely not intentional, and you put the AI in the mix to sort of figure this out, that looks to have a lot of promise. So these are groups that are independently, I think independently, probably with some collaboration, working on different ways to do this kind of smart watch or smart wristband type of detection. And these things are they're going forward in a very intentional way of building these things one step at a time in terms of looking at normal volunteers, then trying to look at things where people's pulse goes away by having some type of procedure done, like a defibrillation for a induced rhythm in the cath lab. But this is how this has to progress. So it's not just a once and done sort of thing, kind of like the Apple Watch was. This is something that needs to occur in an ongoing fashion, as these researchers are doing such a good job with. This is a group from the Netherlands who actually demonstrated this on a person in cardiac arrest. This was a person with an expected death in the hospital, but it did show that the technology had the fundamental ability to discriminate these things. And so it was encouraging. And again, an out-of-hospital cardiac arrest with a person with an ICD in, another instance in which this occurs. So we're seeing that there is research going forward that probably will result in something that will get to where we want to get to. Specificity is really important. Excessive false alarms will overwhelm our system and cause people to discount the ones that matter. So that's what really, really is going to drive this thing in terms of the technology. Now, Google already has a published smartwatch out there which can detect cardiac arrest. And this is some of the background on that. The idea with this particular technology is how much could it really affect it? So this particular study looked at what would happen if the sensitivity ranging from 50 to 100% looking at the number of cardiac arrests were unwitnessed, and they thought that somewhere on the order of up to 1,000 or greater additional individuals could survive over a 2-year period if we were to implement this type of technology. Again, that's a supposition, and it has to do with maybe a higher sensitivity than we can allow. This paragraph here is a review of the devices, and the point of this is, therefore, the responsible development and deployment of these devices requires careful consideration of resource stewardship. This makes making design choices that directly minimize false positives. And that's really the challenge, is to get this down to where the technology can actually discriminate between true positives and false positives. So important. So sensitivity and specificity issues will be very important for us. The other thing that we need to consider too is, for the people that we hope to use this technology, are they willing to use it? Is this a group of individuals that will day in, day out wear a device like that on the off chance that they'll be the person that has sudden cardiac arrest? And perhaps with higher risk groups, that won't be such a leap, but maybe for others, maybe so. Other ways to get at our rural challenge is volunteerism, right? And certainly we know about volunteerism. But the idea of crowdsourcing is something everyone on this call is probably aware of, using such things as Pulse Point or Good Sam to try to get people to the cardiac arrest. And of course, the really important point with this is that the vast majority of cardiac arrests happen in the home. So to really have impact on this thing in a big way, particularly in a rural environment, we need to have our situation set up so that people can enter residences. Without that, we have a little bit more limitation to the impact of this. When we look at using these devices, when you look at using crowdsourcing, at least in this particular study, even if you can crowdsource for a variety of reasons, not everyone who has the app is going to respond. How often do they get there before EMS? Have they done anything when they got there? You know, one in four. Have they been able to put an AED on? Not frequently. And if there was an AED, did they shock? Well, 35%. That is great. But is this really applied to rural areas in particular? So these things aren't reasons we shouldn't do it, but these are things we need to consider as challenges when we try to move to the crowdsourcing approach to getting help in rural settings. When we do this in an urban setting, you use radii from where the event occurs. And with your population density, you can predict how many alerts need to go out or what the radius is to get that critical mass of people who could or could not respond to get somebody to the scene. And this particular study saw that the minimum density of responders has to be 10 per square kilometer to affect this. Now, that may depend on the type of responders you have, et cetera, but there is a population density and a user-based density that becomes important in these things. So it's another sort of thing we need to figure out. As we look at the strategies for this, we need to involve our communities. We need to get the community spirit involved. We need probably to employ technology in this. And when we get all of these bits and pieces together, perhaps we can push the needle on survival. People talk about drones, right? So we're going to send drones with AEDs to these events. And again, seemed pretty far-fetched before, seems less far-fetched now. But, there's some hurdles. There's this thing called line of sight navigation and getting past that so that we can actually deploy these beyond line of sight. And that's done. I believe there's a project up here in Alaska right now doing non-line of sight delivery of different products with drone, but it's by no means universal at this point in time. So again, something to think about, could be very helpful, but will require some resources and some change in some regulations. And of course, in Alaska, there may be people that object to having filming devices flying over their heads, and things could happen. This is another resource that we bring to bear, is law enforcement deployment. And these great public servants are out there more mobile typically than EMS, out cruising and doing things. So as we put defibrillators and knowledge and training and empowerment with our law enforcement partners. We have folks that can deliver AEDs and life-saving CPR to folks and bridge a lot of the gaps that we have. And of course, we don't want to limit it just to law enforcement. Again, they're great partners in this, but other public works people, people that are the linemen, line women, the people that are out on with mobile resources should be empowered, trained, and have AEDs to also find another leverage point for getting people to it. So when we talk about out-of-hospital cardiac arrest, is our success an expectation or simply a goal? Is it an expectation that everybody who suffers ventricular fibrillation, wherever they are, is the expectation that they would survive? Or is it simply a goal? Because just hoping this is going to happen cannot be a successful strategy. So our challenges involve our volunteerism, the fact that we do not have, the ability to provide as many people in perhaps the timeliest fashion in a rural environment as we can in an urban environment. That the training becomes more of a challenge as opposed to more urban areas. And how often does the whole team get together as sort of who responds, from who has the opportunity to respond from their homes in this setting? Again, we have less opportunities to do the event on people, so the training and the sims become very important because we just basically have less opportunities. And as opposed to urban environments where we bring 3, 5, 7, 9 people to bear on this problem, in the rural areas, we have one person showing up, another person showing up from another area. So the coordination and kind of the choreography becomes more challenging as well. And quite likely it's going to take us longer to get there. There may be some difference in the demographic as well. The receiving hospitals are different. This is a different kind of environment. This is a different kind of problem that we need to continue to know is different. It needs to be something that we need to take on as a challenge that can be met. 1 in 5 of us live in a rural area. We have the challenges that I've talked about here. We've got distance, time, notification challenges, and we're looking for solutions. The chain of survival may be a little bit altered, things that we need to work on to improve for our rural comrades. And we need to make sure that everyone who is providing care is working at the highest possible level that we can get them to. And we need to look at sustainability of our overall EMS service in a rural area, because this is not guaranteed with our current funding model. And it also comes down to values. This stuff will cost money. What's our value system? Is this something that we want to invest in? Do we want to invest in a different outcome? So I'd say, we need to consider this a call to action. We need to consider how we can improve our rural outcomes. We need to improve our collapse recognition. We need to improve how we deliver CPR through resuscitation academies, definitely improving our TCPR, how we do crowdsourcing and how we can enhance that. We need to get more AEDs out into the community. And how are we going to do that? Various ways, law enforcement, other sorts of providers, community AEDs at a central spot, using drones perhaps. And then how do we get to higher levels of care? How do we prognosticate who can survive, who would stay in that area because of high probability of futile efforts? Regionalization of resuscitation centers is an approach to this. Telemedicine and leveraging resources in the larger communities to the smaller communities. Using air transport with higher levels of care, including ECMO, to bring people out of rural communities into tertiary care. All these become possibilities. So in summary, when we improve outcomes from rural out-of-hospital cardiac arrest, we should be able to say that where you live should not determine if you live. You can give up some things to live in the country, but you shouldn't have to give up everything. So with that, I guess we're going to leave a few minutes for questions, and it's been great to be here. I thank you for your attention.
Wonderful. Thanks so much, Dr. Levy. Um, I need to apologize when I introduced Dr. Levy earlier. I totally skipped over the fact that Dr. Levy is a member of our advisory council at the Stone and Cardiac Arrest Foundation. So I should have led with that, but wanted to thank you again, Dr. Levy, for your partnership with the foundation and serving in that capacity as well. So go ahead and put in your questions into the chat, and we will cover as much as we can. As a reminder, this is being recorded, and so we'll share the link with you when it's available if you wanted to rewatch it for or share it. That would be great. So there is a comment here. Communities providing free CPR courses would help. When I was first certified, the local fire department or offered the course for free. However, as time went by, it became paid. In rural areas with economic hardships, this became a disincentive for the public to be trained. Policy change would benefit rural communities. Do you want to comment on that or? Oh, you're muted.
Mr. Jones makes a very good point, and I would say that starting a program is not the same as sustaining a program, and starting is a little easier than sustaining. And that's one of the other challenges we have is, probably people like Hal there and many others, they, myself included, you start something, but so many other things going on. So finding someone who can champion these things and putting the process in place so it becomes just something we always do. We popularize this with the community to make sure they come in, why they need to do CPR. You go to faith groups, you do all these things, but you have to keep doing it, and that's one of these things that is a challenge. That's why SCA and others are so important to us to help us continue to get the word out and get people interested in then being the ones that provide this for them.
Yeah, absolutely. And while before we move on to the next question, I just wanted to piggyback with a resource. So at the Sudden Cardiac Arrest Foundation, we have a program called the Heart Champion Program, and these are local, it's our volunteer advocacy program. So anyone that is interested, I'm gonna pop the link in the chat to sign up and get access to. We have a lot of digital resources, and we also activate champions. During October, we have the Ready to Respond campaign. And this is where we empower folks to partner with us and host Ready to Respond events across the country. So anyone that is looking to bring training into their communities, we provide resources and guidance and support to do that. And lots of different opportunities. So I am gonna so that the goal with Ready to Respond is it is a hands-only training. It's not the goal is not certification. It's really just to empower people to feel to improve their confidence and their awareness to be able to step in and help if needed. So I just wanted to mention that. So I'll stick the link in the chat as well. There's another question in the chat here. Has anyone used lodging taxes to fund public access AED programs and training for citizen responders? We just started our first with 25,000 in Upper Kittitas, I don't know how to say this, Kittitas County, Washington, and hotels will be used for 24/7 access. And also Pulse Point and Avive AEDs connected via rapid SOS to the 911 dispatch.
Yeah, I mean, these are great ideas. This is, I think, just trying to flush out whatever monies might be out there to find novel ways to get these devices into the community. I think that's great. I haven't seen the lodging taxes, honestly, but that's another great idea. And it sounds like Daniel Moorbacher, they're using leaving the devices at the hotels so that people can have access 24/7. Sounds great. Also mentioned Pulse Point. I think Pulse Point being able to tag AEDs so that can be seen by dispatch, and then Avive is a brand that is doing some novel stuff. You can see that online with regard to trying to get communities involved and providing AEDs to communities to try to move the needle.
Great, thank you. Another question is, should we not have an upper limit for expected possible SCA survival?
Oh, that's a very pragmatic question, Brian. I think that while that may be true, And it certainly can be approached with regard to what the rhythm was, et cetera, and downtime, no flow time. Um, I guess we like to think sky's the limit. I think your point probably is sometimes that can be a little defeating for us because we always think we should be shooting for the 50s and 60s, and maybe that's not entirely reasonable, rational. So that's a good point. I don't have an answer to it other than that. And maybe others do.
Okay, thanks. There's another comment here. I am in home health. My organization requires us to take a hands-on CPR course quarterly via RQI, which provides real-time feedback on the quality of CPR with depth and frequency. Is anyone familiar with RQI? Want to comment on that?
Well, I know we have at least one person I see in the audience there who's very familiar with this because she helped develop it. But the idea here with that basically is higher frequency, lower dose training, where people continue to get that motor feeling, the muscle memory going, and that as opposed to having these bigger courses for a full day, which kind of sometimes burn people out a little bit, as opposed to going in and getting some hands-on, but not doing it for a full day. And you've seen these in airports and the like. They've had different AHA and others may have had, maybe Red Cross had these where you just do a little bit of CPR as you went through an airport, just an opportunity to see what it feels like and that kind of thing. I think that's a great tool.
Great, thank you. Another comment, we can do better at supporting citizen responders post cardiac arrest. This can be traumatic and few systems follow up to answer these concerns, especially when the outcome is not good. And I will hand this to Dr. Levy, of course, but I just also wanted to put a note out there that we do have the Cardiac Arrest Survivor Alliance program, or CASA, which is our peer support community for anyone touched by sudden cardiac arrest, including survivors, co-survivors, advocates, and lay responders, and rescuers. So I'm going to put a note in there, and that's one of the things that we want to be more intentional about to build out more resources and support as well. But I'll pass it to Dr. Levy for comment on that too.
Now, Jenny, your point was really well taken, and CASA is really a great asset for the world. But Daniel's point is really well taken. I really like it when the EMS folks, if the situation allows, is opposed to pushing that person away that's been there for some period of time, trying to do their best. If we can bring them back in, let them be down at the patient's feet or somewhere where we can continue our work and let them continue to see what's going on and how this progresses. I think that can be really impactful as opposed to just, we're not trying to be mean, but we'll often kind of push people out of the way because we're kind of doing our thing and trying to get set up. I think there's a balance point there. And then also your point about finding what that person's name is, giving them a call, and telling them how it turned out, good, bad, and different. People feel maybe responsible sometimes, that maybe they could have done more. Maybe they should have done less, just all kinds of things run through people's minds. So the ability to get back, and if you have the resources, that's a huge thing you're bringing up there, Daniel.
Okay, thank you. Another comment from a survivor. I had a sudden cardiac arrest last year and survived because the system worked for me. We need more training and education for higher survival rates.
I agree.
All right, if anybody has any final questions, feel free to pop them in the chat. And in the meantime, I also want to just share with you all some upcoming events from here. So let me just pop this back on. So thank you again, Dr. Levy, for this great conversation. Are you able to, I don't think I'm sharing the right, sorry, it's not working. Let me try again. Apologies. Um, I wanted to show you our upcoming events. We have a lot coming up. Okay. Okay, I think you should be seeing my thank you for joining us today. Yes. Okay. I just wanted to note that we have some other upcoming events if anyone is interested in joining one or more additional events coming up, but we have a CASA orientation coming up next week for anyone that's a member of CASA. If you're new or if you've been in there for a while and you want to just meet other people and connect and learn more about how to maximize the connection of the resources, we'll be going through the platform. We have a couple of webinars. So the first week of June, as many of you know, is the National CPR and AED Awareness Week. So we have a whole campaign that we'll be announcing soon. And as part of that week of awareness, we're hosting two webinars. One is on bringing AEDs to your community. And then the second one later in the week is a panel of rescuers are going to be sharing their experience with us. And then we have another webinar in June on focus on survivorship and insurance and financial planning after cardiac arrest. So just wanted to note that we have an upcoming events page, so feel welcome to join to visit that and stay in touch on all of the latest announcements. But I just wanted to let you know about that. There's one more question. Is there an opportunity for low cost single use AEDs for use in the home?
Uh, Great question. I don't have an answer for it. In terms of the single use in particular, I've seen some demonstration stuff with that, but I'm not aware of anything like that, which is not to say it doesn't exist.
And
There's other manufacturers that do have certain things that you can find on the web in terms of subscription programs and stuff like that, where a person can get a device for the home.
And we have a program called the Partners in Preparedness Program. So I will pop the link in the chat for that as well. And that's where there's a variety of discount programs that we're able to extend through our partnerships. So let me quickly stick the link in the chat for you all as a reference as well. Okay. Okay, so that's in the chat. I think we've covered all the questions. I just wanted to thank you again, Dr. Levy, for joining us and sharing your time and expertise with us this afternoon or morning for you.
Great. Yeah, appreciate that. Very nice. I appreciate the opportunity to talk and see some friends' names out there and maybe make a few new ones. So thanks so much.
Thank you very much. If anyone has follow-up questions or would like to connect, I stuck my email in the chat as well. So, oh, there's one more question, if you don't mind. Is there a school program for 11th and 12th graders in rural areas that allows them to participate in volunteer work and community service as part of their academic preparation?
Well, I don't know. Um, I don't have anything like that in my world. Um, there might be others on the call who do know that, but I'm sorry, I don't. Sounds great though.
I would plug the Heart Champion program. We're actually building out a specific cohort of youth champions as well. So behind the scenes, we're getting ready to launch some targeted youth engagement and activation activities to be used for that population. So would definitely welcome follow up on that too. So feel welcome to reach out to me for any questions. Um, all right. I think we've covered all of the chat and thank you all for attending today and joining us. We're really grateful for your involvement. Oh, one more. Um, in New York State, HOCPR training is a requirement for graduation, and we have engaged schools and students in pulse point and AED registration. That's great. Um, okay. And folks are saying thank you. Great information. All right, I think we are all set. So thank you again, Dr. Levy, and thank you everybody for coming and have a great afternoon. Take care.
Bye.
Bye.